So I'm going to talk a little bit about my experience. This is my 20th trip here. I've been working with Dr. Diefenthal for quite a while, and his wife Ro, and we're extremely happy with our graduates from the Diagnostic Center. As most of you know, you cannot treat breast cancer unless you can find it. And that's the biggest problem in Africa today. How do you find it? How do you find it early enough so you can treat it, and how do you get good results? And so that's what I'm going to try to go through today. So you all know where you're at, and we just had a nice summary. And I'm going to talk a little bit about, here's where KCMC is. This is where I was 72 hours ago on top of that mountain. And we got Mark Jacobson with us today from Arusha. And you can see northern Tanzania takes about 18 million people in this area. And when we meet with the Minister of Health, they say, we would like to take care of all 18 million people. And we want to find all the cancer in the 18 million people. And so this is Dr. Diefenthal's house, actually, and it's a beautiful place. Here's the mountain, and it's actually a fantastic view from right there. This is my house when I left 2 weeks ago, and I hope it's all melted when I get home. So we've had 110 inches of snow this year and 60 nights of sub-zero temperature Fahrenheit. So it's been really a bad winter for us, so I'm really happy to be here for that reason. So this is the hostel that we built for the ophthalmologist and for the radiology residents. It's it's about 10 or 11 years old, maybe older than that now, it's almost 20 years old. And East Africa Medical Foundation, which is one of the foundations I'm on the board in Minneapolis, built this for our residents and AMOs and MDs to come and to train here at KCMC. And of course, here's the mountain again. And a nice day when you come to work. The best thing about this place is you come to work and you actually, if you're having a bad day, you can look up here and you can see the mountain. And this is Dr. Diefenthal and Ro. And Dr. Diefenthal has done a great job of training the last 25 years. And you'll see a map. He's trained over 120 AMOs and MDs in diagnostic radiology. At first, when he came, the medical people, including WHO, thought that this was a waste of time. Said there's no reason to train all these diagnostic people. But if you have good diagnosis, X-ray and lab, you can make good decisions. And even if you don't have all of the therapies available, at least you can triage it. You can figure out who you can treat and who you can't. And so that's been the greatest asset, I think, here. So 25 years of service to Dr. Diefenthal. We're going to honor him tonight at dinner. And most of you had a tour of the hospital, so all of you from the hospital, I apologize. I'm going to go through this for our guest to see what the hospital looks like real time. This is the ER, the casualty area. This is the waiting area for ultrasounds. Ultrasound is probably our main tool for diagnosis. I'll show you that. And X-ray would be second, and CT would be third. This is Dr. Diefenthal teaching some of our residents. It's still done with film. And you can see kind of the learning. He's got 3 conferences every morning. And the physicians come down from the hospital. He's got a unique dictating system. It's all handwritten. If it's an emergency, the resident has to run it up to the floor. Good exercise, good response, and the physicians know the response right away. So it's an amazing system, actually. Actually, Mayo Clinic used this up until a couple years ago. So this is a couple years back. This is yours truly teaching how to do a biopsy. So Dr. Dusenberry is in the second row over here, and Dr. Diefenthal is teaching in various aspects of radiology here. And I won't go through all this, but basically this is about KCMC, and our main diagnostic for any illness or mass is with ultrasound. And I actually don't know how many ultrasound units we have now, but we've gotten, how many? 5. Dr. Diefenthal says 5. And we now have 9 ultrasounds for our residents that are going out in training. We're trying to accommodate all of them with some sort of a portable ultrasound unit. And this is our classroom over the hostel. You can either use the blackboard or use PowerPoint. It's really kind of a nice system. Every night there's a lecture for our residents. And this is some of our residents, Dr. Diefenthal teaching again, but some of our residents from the United States, University of Minnesota, Mayo Clinic actually have an exchange program that our residents can come and take part for a month in the rotating program here with Dr. Diefenthal. And this is just some of the surrounding area. This is one of our residents from Mayo Clinic. And this is a resident that now is at University of Minnesota who's doing some pediatric care here. So this is my first trip, I think, to Africa. And this is the first mammogram that was in Africa ever produced. This is back in '88. This is an older machine, but I was kind of dumb enough to actually try to lift it off the end gate of the pickup truck when it came down in the box from Arusha. And so in those days, we basically had to put it in and we hooked it up. We did mammograms. So we still have mammograms here. We're on our third, I think, or fourth generation row of doing mammograms. Here's the one problem we have with diagnosis, and that's the laboratory, probably the weakest link in the chain for all of Sub-Saharan Africa. And here I'm doing a core biopsy. And to do the core biopsy, I actually had to find the formalin on the third shelf back. And I went back and I tried to find it in the lab. And they said, you know, it's look up on the third shelf. And there's only powder. I'd never seen formalin powder before. I had to mix it myself with water. And so I actually didn't know how to do that. I had to look it up, and so we mixed it. And so, but core biopsies are a real diagnosis for cancer. You got to have good pathology or you don't know how to treat it. And so the people from Duke, John Bartlett, and the other people have done a great job of trying to set up the infrastructure for laboratory. And I think that's going to be a huge plus for KCMC to have a great lab. And this is another biopsy that I did when I was here. The typical ward. I won't go through all the costs, but basically this is what the patients, I think it's gone up a little bit since I did this. Ultrasound is $3, and we have a lineup maybe of 60, 70 patients that Dr. Diefenthal does. And so the CT scanner, when we get it back going, is somewhere around $50 to $80. So it's very expensive. The East Africa Foundation actually is a fund to help fund some of the contrast for that. Excuse me. And this is just kind of the surrounding area. And these are some of our graduates. This is from 206. We have between 6 and 10 graduates every year. And some are MDs, some are AMO. And this is where they are. This is probably the biggest legacy for Dr. Diefenthal. This hasn't been updated yet, but there's 20 graduates in the program that are being trained now, but there's 103, I think, out. And they're AMOs and MDs. And so they've scattered throughout East Africa, including Tanzania. We have some in Zambia, Mozambique, and Kenya, but most of them are here. So the key to all of this cancer treatment is trying to find the cancer early enough in one of the village hospitals to get it referred. And if we can get it referred here, you can treat it here. That's the goal. And so this really is outstanding work from all of the people at KCMC to train these different people to go to the hospitals that need to find this cancer early enough. So this is an important slide, and I apologize for the size of it, but this is the Kilimanjaro, and here's the mountain. And here's Bugando, which actually has a very nice cancer center. These are the facilities available today. Bugando hasn't begun yet, but they actually have 2 radiation units, 2 cobalt units, and 2 brachytherapy units. And tomorrow, I think our physician friend from Bugando is going to talk. And it's an amazing project. I have not seen it myself yet, but the idea, here's Ocean Road, which actually has 2 cobalt units. They have a third that's down right now. They do have a brachytherapy unit. Most of that is palliative care. There's very little curative care there. We're trying to figure out how we can do curative care because the pediatric Wilms tumors and other tumors we want to actually get a cure for. And this is the Arusha Lutheran Hospital, which is up in Arusha, which Mark Jacobson runs, who's up in the back row there. And this is the Dodoma project, which is just now being finished. And when we last met with the Minister of Health, they would really like KCMC to be the center of the training, but they'd like a spoke and hub approach. They would like these other hospitals all connected. And with fiber today, you probably could connect all of these for cancer care and diagnosis. So that's the idea, is to try to set up regional. When we first did the analysis for northern Tanzania, it looks like we need about 27 units. Not 2 or 4, but eventually 27. So Eventually, I think the training center would be here, but these other hospitals would probably have a treatment unit of some sort. So I'm going to switch just for a second. I'm going to talk a little bit about breast cancer because that's my specialty back at the University of Minnesota. I'm going to tell you how I'm a translational research scientist. I try to figure out, I got really smart guys in my lab. I'm trying to figure out what's going to work in the clinic. And believe it or not, there's tremendous things that could be used here that we will never have in the United States even, that'll be developed. And so I'm going to talk a little bit about breast cancer. We already saw the statistics. I won't go through those. This is what the bad breast cancer looks like. This is terrible. Unfortunately, most of our breast cancers here come not this bad, but they come with a big lump. And the way we make the diagnosis here is with ultrasound. So mammography is still the first mode to try to find breast cancer in the States. That's how we use it. And so it detects about 85% of breast cancers. And dense breast, it doesn't do quite so well. And this is a digital mammogram. And these are getting cheaper and cheaper. Will KCMC ever have a digital mammogram? Yeah, I think they will. I think it's going to be cheap enough that we'll be able to put it here and it'll be effective. So this is a dense mammogram. Hard to see a tumor in here. This is a traditional film mammogram. This is the digital mammogram, so you can see through the dense tissue much easier. But ultrasound is still the way that we make most of the diagnoses. This is a hypoechoic irregular mass. We can tell, we can measure it. You can see it in 3D on ultrasound. And you know, this exam costs $4, and the other exam costs $350 in the States. So this is MRI. Why do I show you MRI? Well, one, you can see it 3D. Two, there's huge breakthroughs in MRI, almost like radiation therapy. In our lab, we're trying to figure out, this is a $2 million machine, and for a home run in America, it has to be 10 times cheaper, 10 times faster, and 10 times better quality. That's hard to meet those statistics. But there's a way to do MRI called SWIFT that we can use an inhomogeneous magnet. We can bring the cost down 10 times. We can do this for $200,000. And so will KCMC ever have an MRI? Yes, they will. And in fact, in the plans, if you look out there, there's an MRI suite in the cancer center. So how do we do that? Well, we take an inhomogeneous magnet like this one, and this is just a schematic drawing. It's not going to look like this. But, and we use a SWIFT, which is a software hardware change, and we can do this for under $200,000. The cost to the patient somewhere around $200 or $300. I'll show you some of these images why this is important. Here's a first clinical breast MRI was done in the States in 2000. Actually, Germany developed this technique 30 years ago, and we were kind of slow in the States to follow. And so the Germans actually have more experience on this than we do. And so why do we do this? Because of we can see the size of the tumor. It's better for treatment for radiation therapists, surgeons, and others. And we can see additional masses in the same breast that we missed on mammogram and ultrasound, and masses in the opposite breast. We find 3% cancers that we missed when we work them up. So we do MRI on everybody to stage the tumor. And we also can see metastatic nodes to the axilla, and find the cancers in the opposite breast. 3% of the time we find a cancer in the opposite breast on MRI that we missed on mammogram and on ultrasound. This is what it looks like. These are dedicated coils. This is the MRI scanner. And the table just slides into the magnet. We do a pre-contrast scan, then we do a post-contrast with gadolinium. It has to be injected, but the subtraction images show you the cancers. This is one of those cancers. You can see the feeding vessel. You can see the tumor. You get a 3D image of this. So our radiation oncologists like this, our surgeons like it. They can figure out, do we need to do a lumpectomy? Do we need to do neoadjuvant chemotherapy, chemo before the surgery or not? And most of it's based on a biomarker. This is an incidental cyst in the liver. Here's a cancer here, another cancer on the other side. And again, you can see this feeding vessel. This is 2 minutes, 4 minutes, 6 minutes. You can see the contrast go into the tumor. You see it start to drain out. And here's a peripheral enhancement. So this is a breast cancer. Again, a dense breast. These are a couple of cases. I just want to give you a couple of examples. There's a patient presented with a right breast lump on a dense breast. And this BB points to where there's a palpable marker. Hard to see a cancer here. And this is the growth of this over time. This is the ultrasound of that lump. hypoechoic irregular mass. So we can do this right now with ultrasound, but here's the MRI. You can see the draining vessels, and you can see there's no other masses within either breast. Here's another dense breast with a palpable mass. Can't see the cancer on mammo. Big mass on ultrasound. And here it is again on MRI. So we like these images a lot because you can see the 3D aspects of it. You really can't treat these cancers. You can see the depth of the tumor and the extent and the volume of the tumor. And so this is a PET scan which lights up the lymph nodes that are abnormal. We don't do PET scans on breast cancer usually unless we expect metastasis to the bones. All right, last case I think. This is really, really dense breast. Again, a palpable lump, hypoechoic mass. And ultrasound's quite good, and it's inexpensive. 1.4 by 1.5 centimeter tumor, and it's located at 11 o'clock, 7 centimeters from nipple. It gives you pretty good information. But you can see this is breast has got background enhancement, but it's got a fair amount of cancer within the breast. And here's the cancer, 2 minutes, 4 minutes, 6 minutes, and it's a little bit blurry, but you can see the peripheral enhancement of this tumor. So MRI detects nodule in the 6 o'clock position. This is the nodule. So we actually have a method to biopsy these under MRI. And once we get tissue, we don't treat anything unless we have tissue. So you have to have tissue, you have to have biopsy, you have to have lab. And so until we get that, we won't be able to have a cancer center that we can treat known cancer. So these are the screenings we do for MRI. This is the treatment today that's available in Africa. Most of these receive lumpectomy or mastectomy, modified radical mastectomy. I'm not a surgeon, so I won't go through this, but this is the treatment available here at KCMC. I think if we can find earlier cancer, we'll be able to downstage these. I just want to tell you about a new trial in the United States, that's genomics, which actually, if you get a cancer institute developed here, you could do these studies. That's the unique thing. This doesn't have to be a developing country cancer center. This could be first class. And as Radiating Hope will tell you, in 2 days, all this information is out. But you can apply for an NIH grant, you can apply for an NCI grant, and we can get it. And Duke's done a good job of combining these grants for infrastructure with KCMC. So the study we're doing is called I-SPY 2. You can look it up on the internet. It's a neoadjuvant chemotherapy study that's being done right now on genomics. Each cancer is controlled by 8,000 genes. We now can map 4,000 of them. We match the drug with a mouse model. There are 480 drugs in the United States that are not FDA approved, that never will be approved. To approve one drug costs $800 million. And so many of these will never be approved in the United States or here. And so what we've done under IRB studies is we've matched the genomic mouse model with the tumor of the human subject, used MRI as a biomarker, and we've matched that up in the supercomputer at Berkeley with 4,000 hits on the genomics. And so far, these are bad cancers, triple-negative breast cancers. These women would die in 5 years. In 3 weeks, you can't find the cancer. And so this is a huge breakthrough. There's no reason why you couldn't study that here. So this is Ocean Road. Most of you know about this. I won't go through this. The pediatric wing of this just moved over to the National University. And radiation, I'm not going to go through because we've got too many experts in here. In the old days, Dr. Diefenthal tells me that we used to be dual trained. You used to have diagnostic radiologists and radiation oncologists were together. And in his first year of training, he was a radiation oncologist. So we don't do that anymore. We split off many years ago. And so I won't go through this, but radiation therapy for post-breast cancer would be very helpful. It would decrease the recurrence rate, decrease mortality, and the possibility to do metastasis with radiation would be fantastic. So in summary, I've tried to talk to you a little bit about breast mammography and use the diagnostic imaging with ultrasound and MRI in some of these cancer studies. And if we get that basic diagnostic equipment here and they teach the radiologists how to use it, which they already know, you can participate in any cancer study in the world. Thank you very much.